I'm Carla Pecoraro.
I'm Mel Akerman.
And I'm Anne Woolfield, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information on all things O&G. Today is our first episode of Evidence with Anne, where we will discuss some of the key studies and RANZCOG landmark trials relating to PPROM. Today we're going to discuss the Oracle 1 trial and the 7-year follow-up, and for completeness we'll discuss the Oracle 2 trial even though it's not directly related to PPROM. It makes more sense to discuss them together. We'll also discuss the PPROM trial, Promexel, and the 10-year Promexel follow-up.
Now, learning the landmark trials can be the hardest, driest, and most boring parts of studying for the RANZCOG written exam. So we're here to make it fun and manageable. First of all, why do we care about these studies?
Well, as you've probably realised by now, the evidence is constantly changing. New studies are being released all the time. But what we're really looking for are those gems that change our clinical practice. Landmark trials are highly influential studies that have substantially changed how we practice medicine or provide the missing evidence to support current practices. There is a list of the important landmark trials that RANZCOG expects you to know on the college website. These do change from year to year though, so be sure to check it before your upcoming exam.
Specifically, what the college wants you to know is the methodology, results, conclusions, strengths, and weaknesses of the landmark trials. Some of the studies you're expected to know in detail, and these are listed on the RANZCOG Acquire website. But it's important to note that this is not an exclusive list, so you should always be aware of important trials that come along. The landmark trials relative to PPROM include Oracle 1 trial and its 7-year follow-up, and PPROM trial. But I think there's also a few really important trials related to PPROM, so we've included those as well.
Sorry. Awake. So many acronyms. How the heck am I ever going to remember these trials?
Simples. Just listen to Evidence with Anne and let her soothing voice embed that knowledge into your brain. Let's start with the Oracle 1 trial. Anne, tell us everything we need to know.
I'm not sure about soothing voice, but here we go.
Yes, you do.
The Oracle 1 trial was one of the key trials that led us to use the antibiotics for PPROM. Ever wondered why we use erythromycin for 10 days? Or why it's so important we don't give co-amoxiclav? Well, it's the Oracle 1 trial. Let's kick us off with the who, what, when, where, why, and how. So Oracle stands for the overview of the role of antibiotics in curtailing labour and early delivery. But the name of the Oracle 1 trial is actually Broad Spectrum Antibiotics for Preterm Prelabour Rupture of Fetal Membranes, the Oracle 1 randomised trial. Who? It was written by Kenyon et al. And published in The Lancet. When? It was published in 2001, but the study period covered 1994 to 2000. And where? It was a multi-centre trial. The majority of the hospitals are in the UK. The aim of the study was, in the setting of PPROM, to test the effect of antibiotics on neonatal outcomes and whether the reported benefits are due to the type of antibiotic used.
Oh, I'm awake. So the Oracle 1 trial is Broad Spectrum Antibiotics for PPROM, the Oracle 1 RCT by Kenyon et al., published in The Lancet in 2001.
And the aim of the trial was to test the effect of antibiotics for PPROM on neonatal outcomes. How did they actually run the trial?
The Oracle 1 was a multi-centre, double-blind, placebo-controlled RCT. 4,826 women with PPROM were randomised to erythromycin, amoxicillin clavulanate, both, or placebo. The exclusion criteria included patients who were already prescribed antibiotics, or if there was any reason that they could not have antibiotics, for example, allergy, or if the baby required immediate delivery. The primary outcome was a composite of neonatal death, chronic lung disease, major cerebral abnormalities on ultrasound prior to discharge. Secondary outcomes included delivery within 48 hours and within 7 days, mode of delivery, length of stay, and maternal antibiotics after delivery. Other secondary outcomes included the gestational age at delivery, birth weight, admission to the NICU or special care nursery, ventilated babies, RDS, oxygen surfactant, and oxygen dependence, and necrotizing enterocolitis or NEC.
Okay, so the Oracle 1 trial was a multi-centre, double-blind, placebo-controlled RCT. These are some buzzwords to remember.
The trial randomised nearly 5,000 women with PPROM to erythromycin, co-amoxiclav, both, or placebo, and looked at the primary outcome, which was a neonatal composite. What did this study find out? Tell us more, Anne.
Okay, so what the Oracle 1 found was the use of erythromycin in women with PPROM resulted in a decrease in overall neonatal morbidity and mortality from 15.2 to 12.7%, with a p-value of 0.08. In the amoxicillin clavulanate group, there was no benefit in the primary outcome, but there was an increase in the rates of necrotizing enterocolitis, 1.8% versus 0.7%, which was highly significant with the p-value of 0.0005. Hence, we do not use co-amoxiclav during pregnancy. Treatment with erythromycin was also associated with an increased length of pregnancy, what we call latency antibiotics, decreased surfactant use, decreased oxygen dependence at 28 days, and decreased cerebral abnormalities on ultrasound. It also reduced the positive blood cultures.
Okay, so let's recap it one more time because my tiny little brain needs repetition.
The Oracle 1 trial is broad-spectrum antibiotics for PPROM, the Oracle 1 RCT, by Kenyon et al., published in The Lancet, 2001.
It was a large, multi-center, double-blind, placebo-controlled RCT, which randomized 4,800 women with PPROM to erythromycin, augmentin, both, or placebo.
Primary outcomes included a composite of neonatal morbidity and mortality, and secondary outcomes included delivery within 48 hours or 7 days and mode of delivery.
The study found that erythromycin 250 milligrams QID for 10 days caused a reduction in the composite of neonatal morbidity and mortality, an increase in the length of the pregnancy, and even reduced respiratory complications. What a dream trial.
Something I really liked about this study was its size. Nearly 5,000 patients. Very impressive. This study was designed very well with the 4 arms to test their different antibiotic regimes. Apart from a meta-analysis of multiple of these trials, you really can't get a better design. And there was also a method to report adverse events. From a limitations perspective, there was no baseline data collected with regard to obstetric history, fetal, or other maternal diseases. The Oracle 1 trial is why we give 10 days of erythromycin for women with PPROM and why we know that co-amoxiclav causes necrotizing enterocolitis. What a groundbreaking trial, and it's the basis behind one of our most common guidelines.
Okay, fine. The Oracle 1 is actually kind of cool. Is it done or is there more? Didn't you mention there was also a long-term follow-up trial for this Oracle 1 mysterious master?
I think she did. You didn't think the Oracle 1 dream team would stop there, did you? Oh no, these guys went the extra mile to make sure that babies exposed to antibiotics antenatally for PPROM were safe.
That's right, which brings us to our second landmark trial. Childhood outcomes after prescription antibiotics to pregnant women with preterm rupture of membranes, a 7-year follow-up of the Oracle 1 trial. This trial was again published by Kenyon et al. In The Lancet in 2008. The primary outcome for this study was an assessment of functional impairment using the Mark III multi-attribute health status classification system. Education outcomes were assessed with national curriculum test results for children resident in England, and secondary outcomes included medical conditions such as convulsions, diabetes, and respiratory diseases.
Ooh, what did they find? Are there any long-term side effects of using antibiotics for PPROM?
Fortunately, no. So for the Oracle 1 trial, the researchers were able to obtain information for the primary outcome in 75% of the eligible children. There was no difference in the proportion of children with functional impairment between the 4 treatment groups. There was also no difference in the overall level of behavioural difficulties or medical conditions, or in their ability reading, writing, or mathematics.
Thank goodness. Okay, so now we've covered the Oracle 1 trial and its 7-year follow-up. Let's get into the Oracle 2 trial just so we can clear up any confusion between the two. And be our Oracle and tell us what we need to know about Oracle 2.
I'm changing your name in my phone to the Oracle. It's done.
Oh, I can't believe you write that bit in, Mel. The Oracle 2 trial is called Broad Spectrum Antibiotics for Spontaneous Preterm Labour, the Oracle 2 RCT. Who? Also by Kenyon et al., published in The Lancet in 2001, with data collected between 1994 and 2000. This is the same as Oracle 1, which makes it nice and easy to remember. What? It's also a multi-center, double-blind, placebo-controlled RCT. Now we've come to a difference. The participants. So there were 6,295 women in spontaneous preterm labour or threatened preterm labour with intact membranes and without any evidence of clinical infection. They were randomly assigned to erythromycin, co-amoxiclav, both, or placebo.
Okay, so to spell out the difference between the Oracle 1 and the Oracle 2 trials. The Oracle 1 trial looked at the use of antibiotics for PPROM. The Oracle 2 trial looked at the use of antibiotics for preterm labour with intact membranes. They were both published by Kenyon et al. In The Lancet in 2001, and they were both multi-center, double-blind, placebo-controlled RCT. I hope everyone's singing that along.
So what were the primary outcomes for the Oracle 2 trial?
Conveniently, the primary outcomes for the Oracle 2 are the same as the primary outcomes for Oracle 1. Hopefully it makes them easy to remember. The primary outcome being a composite of neonatal death, chronic lung disease, and major cerebral abnormality on ultrasound prior to discharge.
Oh, thank goodness, that is convenient. What did this study find? Are antibiotics also useful for preterm labour?
Sadly, no. None of the different trial antibiotics were associated with a lower rate of composite primary outcome. There was no evidence that the antibiotics prolonged pregnancy, influenced the mode of delivery, or length of stay, although there was a reduction in the rate of maternal infection.
How disappointing. But also, thank God there was a study on this. Otherwise, we might have just assumed that if antibiotics worked for PPROM, then surely they would also work for preterm labour. What are the strengths and weaknesses that we need to know?
Similar to the Oracle 1 trial, this was a great study design with large numbers. There wasn't a standardized criteria for the diagnosis of preterm labour or threatened preterm labour, which is a bit of a limitation, but then it also means that it's more generalizable.
Okay, cool. So let's summarize. The Oracle 2 trial is called Broad Spectrum Antibiotics for Spontaneous Preterm Labour, Oracle 2 RCT, by Kenyon et al., published in The Lancet in 2001.
The Oracle 2 was a multi-center, double-blind, placebo-controlled, randomized controlled trial that randomized women presenting with preterm labor to receive erythromycin, co-amoxiclav, both, or placebo.
There was no difference in the composite of neonatal death, chronic lung disease, and major cerebral anomaly. There was no evidence that it prolonged pregnancy.
All right. Where's this long-term follow-up? There's no way the Oracle team did a follow-up study for Oracle 1, but not for Oracle 2.
You're absolutely right. The Oracle 2 follow-up trial was also published by Kenyon et al. In 2008 in the
Lancet.
This study was called Childhood Outcomes After Prescription of Antibiotics to Pregnant Women with Spontaneous Preterm Labour, 7-year follow-up of the Oracle 2 trial. Again, conveniently, the methodology was exactly the same as the Oracle 1 follow-up. The primary outcome for both follow-up studies was an assessment of functional impairment using the Mark III Multi-Attribute Health Status Classification System. Education outcomes were assessed with national curriculum tests for children resident in England, and the secondary outcomes included medical conditions such as convulsions, diabetes, and respiratory diseases.
Ooh, and what did they find? I'm guessing that if antibiotics caused no problem for kids exposed with PPROM, then surely they wouldn't cause any harm if used in preterm labour.
I mean, that makes sense, but sadly you're wrong. Once again, proving the need to research everything. For the Oracle 2 trial, the outcome was available for 71% of participants, but there was actually an increase in functional impairment in the erythromycin group, 42.8 versus 38.3%. The odds ratio is 1.18. There was no effect with co-amoxiclav and no difference between the number of deaths, medical, behavioural, or educational problems. There was an increase in the risk of cerebral palsy with either antibiotic, 3.3% versus 1.7%, and the number needed to harm was 64 for erythromycin and 79 for co-amoxiclav. Hence, we do not give antibiotics for threatened preterm labour.
Oh, that's so interesting. So there were no long-term risks with antibiotic use for PPROM in the Oracle 1, but if you use antibiotics to prolong latency in threatened preterm labour with intact membranes, it increases the risk of functional impairment and cerebral palsy.
Yeah. The researchers obviously went to a lot of trouble to gather this follow-up data. It was very impressive, the lengths that they went to. The parents were still blinded to their original treatment group, but It's important to note that most of the follow-up data, including most of the diagnoses, such as cerebral palsy, were based on parental reports. But it is really nice to have all this follow-up data.
Wow, these trials make our PPROM and our preterm birth episodes so much better. So if you want to go back and listen to them after these trials, that makes sense. Because Oracle 1, antibiotics for PPROM, good. Oracle 2, antibiotics for preterm labour and threatened preterm labour with intact membranes, bad. So let's move on to our next landmark trial, the PPROM trial. Why do we care about this one?
The PPROM trial is important because it is essentially the reason why we recommend expectant management until 37 weeks with uncomplicated PPROM. And hit us with the facts.
The PPROM trial is titled Immediate Delivery Compared with Expectant Management After Preterm Prelabour Rupture of Membranes Close to Term. PPROM trial, a randomized control trial. This trial was published in The Lancet in 2016 by Morris et al., but included data collected between 2004 and 2013. The aim of this trial was to evaluate immediate delivery versus expectant management in the management of PPROM and see if immediate delivery reduced the risk of neonatal infection.
Okay, and what do we need to know about the methodology for PPROM?
PPROM was a multi-centre RCT conducted in 65 centres in 11 countries. There was 1,839 women with singleton pregnancies with PPROM between 34 plus 0 to 36 plus 6 weeks gestation, and they were randomly assigned to expectant management versus immediate delivery. Women with PPROM less than 34 weeks became eligible at 34 weeks. The primary outcome was the incidence of neonatal sepsis, which had a very specific definition in the study protocol. Secondary outcomes included APH, intrapartum hemorrhage, fever, postpartum treatment with antibiotics, mode of delivery, and a composite of neonatal morbidity and mortality.
And what were the results?
Well, if you listen to our PPROM episode, you can guess the results. Basically, there was no difference in neonatal sepsis between immediate and expectant management groups, 2 versus 3%, a p-value of 0.37. There was also no difference in composite neonatal morbidity and mortality in the immediate versus expectant management groups, 8 versus 7%. However, in the immediate delivery group, there was an increase in respiratory distress, which makes more sense because babies were born preterm. So that was 8 versus 5% between the immediate delivery and the expectant management groups, with a p-value of 0.008. There was also an increase in mechanical ventilation and time in the NICU for the immediate delivery group. In the expectant management group, there was an increase in antepartum hemorrhage, intrapartum hemorrhage, use of antibiotics, longer hospital stay, but decreased caesarean section.
Wait, what? A decreased caesarean rate with expectant management? What was that caesarean section rate?
So in the expectant management group, that was 19%, and that was versus 26% in the immediate delivery group. Also, in one of their pre-specified subgroup analyses, they compared the rates of neonatal sepsis in women with and without GBS, and there was no difference. One thing I liked about this trial was that it was quite big. Once again, very important. 1,839 women recruited. The study design, once again, very well done, and these subgroup analyses were pre-specified in their study design. The management in the expectant group was also very practical, which made it much more generalizable.
Yeah, cool. You make studies sound like fun people to hang out with at a party, Anne. I just love it. So it's time again for that summary. So PPROM is immediate delivery compared with expectant management after preterm prelabour rupture of membranes close to term. The PPROM trial, a randomized controlled trial, published by Morris et al. In The Lancet in 2016.
It was a multinational, multi-centre randomized controlled trial which randomized women from 34 plus 0 to 36 plus 6 weeks with PPROM to expectant versus immediate delivery.
There was no difference in the rates of neonatal sepsis and composite neonatal morbidity and mortality. Immediate delivery resulted in an increase in respiratory distress, mechanical ventilation, and a longer stay in the NICU. Expectant management resulted in high rates of APH, intrapartum fever, and use of postoperative antibiotics, but a decrease in caesarean section rates. Importantly, there was no difference in the rates of neonatal sepsis regardless of GBS status.
So PPROM supports a policy of expectant management until 37 weeks in women with PPROM close to term.
Okay, so that wraps up our RANZCOG landmark trials on PPROM. What else have you got for us, Anne?
Well, how long do we have? There are so many trials. I mostly wanted to highlight the Promexil trial. So the Promexil trial, not a RANZCOG landmark trial, but it's another trial quite similar to PPROM, which contributed to the Cochrane review regarding planned birth or expectant management in women with PPROM. The Promexil trial was published in 2012 by Vanderham, and the reason I wanted to include this is because there's been recent follow-up data published.
Cool. Let's start with a quick summary of the Promexil for our listeners.
All right. So between 2007 and 2011, 2 Dutch randomized control trials, the PPROM expectant management versus induction of labour Promexil trials, they evaluated induction of labour versus expectant management in late PPROM. Both trials were published in 2012 by Vanderham et al., one in AJOG and one in PLOS Med. Both trials showed that the neonatal sepsis rate was not reduced in the induction of labour group. There was a lower rate of chorioamnionitis, less hemorrhage, and a shorter stay following induction of labour. However, the induction of labour group resulted in more hypoglycemia and a longer hospital stay for the infant. The conclusion from the Promexil trials was that induction of labour after PPROM near term did not result in a reduced rate of neonatal sepsis.
Loving all of these trials with follow-up. Tell us about the 10-year Promexil follow-up.
So the follow-up is titled Childhood Outcomes After Induction of Labour or Expectant Management for Preterm, Prelabour Ruptured Membranes, a 10-year follow-up of the Promexil trials. It was published in May 2023 in AJOG by Simmons et al. The study aimed to assess the long-term outcomes of children born after singleton pregnancies complicated by late PPROM managed with induction in comparison to expectant management. This was actually a follow-up of the Promexil trials run between 2007 to 2011, evaluating children at 10 to 12 years of age. The primary outcomes were cognition, motor function, and behaviour as assessed by various checklists. The secondary outcomes were sensory processing, respiratory problems, educational attainment, and general health.
So 711 surviving children of the 714 singleton pregnancies randomised in the original trials were invited to participate. Unfortunately, only 248, or 35% of children participated, 127 in the induction group and 121 in the expectant management group.
And what were the outcomes from those children who did participate?
The study basically found that children born after induction of labour had no significant differences in long-term cognitive development, motor function, behaviour, respiratory problems, educational attainment, or general health when compared to those born after expectant management. Put another way, expectant management for PPROM did not improve long-term outcomes for children at 10 to 12 years of age compared to induction. There was a slight trend toward a reduced risk in having a mild delay in motor function in the induction of labour group. However, a larger study population is needed to see if that effect persists.
Now, this is interesting because you would think that induction of labour rather than expectant management would result in worse long-term outcomes because of prematurity. But this study has shown that actually that's not the case.
But important to remember, I guess, that's only a couple of hundred children.
Yeah, true. And I think there were some differences in the group of children who responded and the group who didn't. So the group of children who didn't respond were more likely to be high risk and therefore have worse outcomes. So,
oh well.
Another time, another analysis.
Another episode with Anne. But yeah, my mind is blown, and I know that's a lot of information, but I hope it's been helpful for everyone to both remember the landmark trials, but also to understand the background to a lot of our guidelines. So thanks so much to Anne for sharing her knowledge on the landmark trials. I hope some of this sticks in my brain.
Me too. Thanks for listening to The Uterine Sound. Check us out on Instagram at The Uterine Sound or via email, theuterinesound@gmail.com, or at our website, theuterinesound.com. Let us know if you have any questions, queries, or if you want to fact check us.